Thank you, organizers, for the invitation. And I would like to discuss this World Conference on Lung Cancer paper on phase 3 trial on SAF-189, Crizotinib in first-line ALK-positive setting. So, as all of you know, that lung cancer is the leading cause of death worldwide, and ALK-positive is most common in young and non-smokers and with adenocarcinomas. And CNS is a typical aggressive presentation of ALK-positive lung cancers. So, and although there are many potent second and third generation ALK inhibitors like alectinib, brigatinib, lorlatinib, ceritinib, they are prone to resistance and palindromia. And they still develop, and that includes CNS progression, that leads to CNS progression, which is a major cause of illness and death. So SAF-189, that is Crizotinib, is a highly potent and brain penetrating next generation ALK and ROS1 inhibitor, so dual inhibitor, and has demonstrated promising clinical efficacy in phase 2 studies. So it was an interim analysis which was reported called the REMARK study in this conference. So the eligibility of this study was, locally advanced or metastatic ALK-positive lung cancers, which were treatment naive of ECOG 0 to 2, and it was further stratified into 0 or 1 ECOG PS or 2, and whether or not CNS metastasis was present. So Crizotinib was given in the doses of 160 mg QID and every 21 days cycle, and Crizotinib was, as the usual dose, 250 mg BD. So the primary endpoint was assessment of PFS, objective response rate, the time to progression, time to response, and the overall survival and safety, and also the pharmacokinetics and IRC associated intracranial efficiency, as well as the quality of life. So the patients were screened, around 332 patients were screened. A few of them failed screening, and patients were randomized to around 275. And the Crizotinib arm got around 139, and Crizotinib arm around 136. And there were disease progression noted in the Crizotinib arm as well, of 18 patients, and death of 4 patients, and intolerance of 5 patients, withdrawal by patient 5, and physician's decisions to stop the drug was in 4. And in Crizotinib arm, pretty much disease progression was higher, of 60, death in 1, intolerance in 4, and withdrawal by patient of 11. And so in both the groups, demographically it was more or less equally distributed. And the significance was that in the Crizotinib arm, almost 36 patients versus 20 patients in the Crizotinib arm were above 65 years. And gender-wise and racial-wise, it was both same. And the majority of the patients in both the arms, almost around 99%, 95 to 99% of the patients in both the arms were non-smokers. So ECOG PS, majority of the patients were ECOG PS 0 to 1, and the disease status was, majority of the patients were disease stage 4. CNS metastasis was present in almost equally around 28% of the patients in the Crizotinib arm, and the Crizotinib arm had 37% of the patients. So coming to the primary endpoint of PFS assessment, so the Crizotinib arm did not yet reach the PFS value, whereas in the Crizotinib arm it was around 13.93 months, and it was a significant PFS. The PFS was statistically very significant, and with a good hazard ratio of 0.23. And the secondary endpoint was the time to progression, which was again in Crizotinib it was around 19 months. And again, Crizotinib was quite useful in this aspect also, which had a hazard ratio of 0.04, and again p-value was quite significant. The secondary endpoint overall survival was around, in the Crizotinib arm it was around 2 years, 24 months, and again the significant hazard ratio was, the hazard ratio was around 0.6 favoring the Crizotinib arm. But statistically it was not significant, with a p-value of 0.07. So systemic and intracranial objective response rates was almost, in the Crizotinib arm it was 92%, whereas in the Crizotinib arm it was 80%. And the overall response, the patients with intracranial overall response was almost 100% in the Crizotinib arm, and Crizotinib arm had 50%. So the safety summary was that the foratinib arm was well tolerated without any major grade 3 toxicities. The treatment-related adverse events was observed in both the arms, almost equal, but there was the foratinib arm had significant treatment-related adverse events of hyperglycemia, hypertension, and prolongation of QTC. So grade 3 treatment-related adverse events occurred in 37% of patients of foratinib compared to 55.6 patients with crizotinib. And common grade 3 adverse effects for foratinib was hyperglycemia, hypertension, and prolonged QTC. And there were no interstitial lung disease or visual loss or hallucinations observed in the foratinib arm as compared to the crizotinib arm. So conclusions, the REMARK study met its primary endpoint, demonstrating a statistically significant and clinically meaningful improvement in PFS in ALK TKI-naive NSCLC in interim analysis with a significant p-value and a hazard ratio of 0.23. It also showed significantly improvement of CNS efficacy versus crizotinib, and with a hazard ratio of 0.04, again statistically very significant. And it also showed an improvement in overall survival versus crizotinib, with a median OS of not reached versus around 2 years, 24.94, which was although not statistically significant, but it had a good hazard ratio of 0.6, favoring the foratinib arm. So safety profile of foratinib was as well as expected without any new findings. And these data have verified that foratinib is a new treatment option for advanced ALK-positive NSCLC patients. So with this, I conclude my talk. Thanks.